Now let's turn our attention to hypoglycemia. So I just want to first set the stage with the classification of hypoglycemia, which has been in effect for 2 or 3 years. We were all used to hypoglycemia less than 70 now milligrams per deciliter. I've also put millimoles because hopefully we'll soon all be talking the same language. So less than 70 is level 1. Most studies assess patients who fall below 54 milligrams. So that's level 2. Level 3 is termed as severe hypoglycemia with altered mental or physical status requiring the assistance of another person for the treatment of hypoglycemia. So the patient no longer has autonomic warning symptoms, can no longer get carbohydrates or drink juice or eat a candy. They need help because they're usually obtunded or physically incapacitated. The risk of hypoglycemia, you can read this whole list, but to highlight some things, age itself is a risk. Insulin and sulfonylureas, and I think you saw that in the overtreatment. Overly tight control. Some medications, quinolones, ACE inhibitors, can put you at risk for hypoglycemia. Quinolones in themselves can lead to hypoglycemia. Overuse of sliding scale, insulin administration errors, end organ disease, or increased insulin sensitivity in the case of somebody who's lost weight. Actually, I had a patient call me yesterday who had lost 10 pounds, and on his regimen before, he was fine. But then he dropped his blood sugar to 64. So I actually ended up reducing his sulfonylurea dose and keeping the other things, stable. Undiagnosed hypothyroidism or adrenal insufficiency can also lead to hypoglycemia, and people with physical or intellectual disability or who are dependent on care from caregivers or family. Hypoglycemia is a very serious outcome in older adults. It can not only worsen pain, increases the risk of falls and dizziness, and there is a bidirectional relationship between cognitive impairment and hypoglycemia. So hypoglycemia, especially repeated episodes, can cause cognitive impairment, but then cognitive impairment itself can lead to hypoglycemia. This condition is also associated with cardiovascular complications, arrhythmias, hospitalizations, and of course, it's a very costly episode if you need to go to the emergency room, and hopefully unnecessary in most situations. Just to touch a little bit on diabetes and dementia, I've already mentioned there is a connection. So in type 1, you see some slowing of mental speed and mental flexibility. In type 2, cognition changes, and to the extent that learning, memory, mental speed are affected, and you can get full-blown dementia syndromes. And the longer you've had diabetes, the higher the likelihood. Okay. And also, very interestingly, type 2 diabetes or just impaired fasting glucose is present in 80% of people with Alzheimer's. So just interesting when we talk about that bidirectional relationship. So this study actually showed that the risk of dementia increased in people who had repeated episodes of hypoglycemia. Let me see if I can go back. So more episodes of hypoglycemia increase the likelihood or the hazard ratio of developing dementia, even if you're adjusted for A1C, type of treatment, years of insulin use. It was the number of episodes of hypoglycemia that still pushed the trend towards developing dementia. The treatment of hypoglycemia has not changed. The rule of 15 still applies. So in a conscious patient, you can give them 15 grams of carbohydrate or glucose, which is half a cup of juice, not 12 ounces of juice with sugar in it. Okay, half a cup of applesauce, milk, glucose gel, even 3 marshmallows. Okay. So I often look at my patients' handbags. Of course, I ask their permission to see if they have some carbohydrates. So they have glucose tablets. What are they carrying for an emergency? Then you wait 15 minutes, recheck the blood glucose. If it's still low, give another 15 grams of carbs. Of course, in an obtunded patient who is unconscious, you're going to require glucagon. Or if you have an IV line or can start one, then intravenous dextrose. You don't need usually the full 50 milliliters of 50% dextrose. Sometimes half that amount is perfectly sufficient to treat the patient. So the ADA recommendations for hypoglycemia is basically be vigilant about and ask about hypoglycemia at every visit, document that question, and look for cognitive impairment because those people are more likely to make mistakes, develop hypoglycemia. And in older adults with type 1, and I'm using continuous glucose monitoring now with older adults with type 2 who are using injectable treatments, that may be a good alternative, especially somebody who's brittle and prone to hypoglycemia. Glucagon should be prescribed to everybody who's at risk for hypoglycemia, less than 54. And then you have to also train family and caregivers in case the patient gets severe hypoglycemia. There's also this entity of hypoglycemia unawareness, where the person doesn't have the warning time between the hypoglycemia, sweating, palpitations, hunger, fear. They don't have that. There's a very short warning period and they can collapse and require assistance. So hypoglycemia unawareness is important. And how I pick that, I look at the glucose log or their CGM records, and I see low blood sugars. I say, how did you feel with that? And if they say, oh, I felt fine, that's a red flag because they were unaware of that hypoglycemia. Just to show you some glucagon delivery systems. This is on the top is a standard glucagon kit. A little bit cumbersome in a panic situation. Mixing the powder, drawing it up and injecting can take what seems like an eternity. We now have nasal glucagon, trade name is Baqsimi, which can deliver 3 milligrams of glucagon, one squirt into the nares. And that works actually just as well, very easy for non-trained family members, any caregivers. And now we have Gvoke, which is also glucagon pen, pre-mixed, easy to inject, and no significant training is required.